Hello, everyone, and thank you for joining us for our always popular questions and answers panel. I hope you've been enjoying today's sessions. To start, I want to remind everyone to ask your questions during this. Please use the live Q&A tool on the right-hand side of the portal. We are very happy to have with us today Dr. Lauren Pinter-Brown and Dr. Jina Chung. Dr. Pinter-Brown is a board-certified, fellowship-trained UCI hematologist-oncologist who specializes in the diagnosis and treatment of patients with lymphomas. She is a nationally recognized expert and has a long-standing interest in malignant lymphoma with a particular focus on T-cell and skin lymphomas. Dr. Pinter-Brown is also a past Cutaneous Lymphoma Foundation board member. She has provided invaluable support to the foundation from its early beginning. She has served on our scientific review board and our medical advisory board. Dr. Jina Chung is a board-certified dermatologist and dermatopathologist, and she is the director of the Cutaneous Lymphoma Clinic at Oregon Health and Science University in Portland, Oregon. She sees patients with both T-cell and B-cell lymphoproliferative disorders in the dermatology clinic, as well as in a multidisciplinary clinic with oncology. She regularly participates in the teaching of residents and medical students in both dermatology and dermatopathology at Oregon Health and Science University. One last thing before I bring them on screen. Please note that the doctors today are not providing second opinions. They are sharing their knowledge and their experiences. Thank you both for joining us today.
Thank you for having us.
Thank you.
All right, we're going to get started with our first question. And this one is always, it's going to be nice to ask the two of you. Who are the best doctors to treat mycosis fungoides? I see an oncologist and dermatologist, and they each say the other should be the main source of treatment.
This is such a common question, isn't it? And I always answer the same way. You should go to somebody that understands this disorder, and it really doesn't matter if they're an oncologist or a dermatologist. I'm sure that most of my dermatology colleagues that are interested in this area, they know far more oncology than most dermatologists, and I probably know far more dermatology than most oncologists. So I think that you just need to find someone that understands your condition.
Yeah, I think that's very true. I think that in general, it also kind of depends on your stage, like who tends to kind of have the more primary role in treatment. I think that in my experience, at least at our center, people with more early stage disease tend to follow primarily with a dermatologist because they tend to get more skin-directed therapy, whereas people with more advanced stage disease, such as Sézary syndrome, often tend to follow with oncologists, with dermatologists also involved in their care.
Okay, thank you for that answer. It is one that we do get a lot here too. So one of our questions is about, have there been any studies between the connection of the microbiome in the gut and the symptoms of CTCL?
A really good question. I'm not quite sure. What do you think, Dr. Pinter-Brown?
I think I've seen some abstracts, but not anything in publication. It's a very interesting topic, but I think one that we don't really know what the connection is.
Mm-hmm. Yeah, I agree. I don't think there's a lot of good evidence to show that there's a connection.
So I think our second question is a good starting point on the fact of we won't always know the answers to the questions, and some of the questions will be so specific to a patient that the doctors wouldn't be able to answer without seeing your records. So let's just it's a good start to say we can only answer what we can answer. Okay, our next question is, can my questions are sliding. Can MF-CTCL be painful? Will it cause swelling and joint pain?
The mycosis fungoides patients that I see often do experience skin pain, especially when they have really extensive skin disease. Sometimes it can cause like sores on your skin that won't heal. And I do think that skin pain is a symptom that patients often experience. And sometimes when they have extensive disease, they can get swelling of their kind of limbs as well, especially like if they have skin disease that's covering their entire body. often those patients can have a little bit of leg swelling as well. I don't have a lot of patients who experience joint pain with this condition. It's not a disease that typically involves the joints. What do you think, Dr. Pinter-Brown?
There's some really old reports of joint involvement, but I would agree with you. In general, if someone had joint pain, I wouldn't think it was from their cutaneous T-cell lymphoma.
Okay, thank you. So this next question kind of ties in a little bit potentially with it, is that do you know of a connection between rheumatoid arthritis and CTCL?
Well, that one's a lot easier. So all lymphomas are seen in higher numbers in people with autoimmune diseases, including rheumatoid arthritis. So that one's kind of an easier answer, I would say.
All right, that's good to have an easy one in the beginning too. Next question is on UVB light therapy. Is there a recommendation for a maintenance dose of it? I had a year of it and was wondering if I should continue as a preventative measure.
It's a really good question. And I think that there's not necessarily like a right and wrong way to do this. I have some patients who have a home UVB light machine, and they do it about once or twice a week just as a maintenance therapy on a lower dose. But some patients, if they're doing really well, they might also taper off. And if they wanted to taper off, I might say you could do it like twice a week for about a month, and then go down to once a week for about a month, and then stop. And then if you get flaring of your mycosis fungoides again, then you can restart treatment. But I don't think there's necessarily like a need to do maintenance, but I think you can, because it does help keep the disease in remission.
Some people, that's such a controversial topic. Some people might want maintenance if their disease comes back very shortly after a taper. Mm-hmm. I generally don't maintain patients, but I have some patients that are doing maintenance because very shortly after they stop their light therapy, it comes back, and then they have to rev it all back up again. Right. But some people, it can even be maintained as infrequently as once a month or once every 6 weeks. I think that the treatment be very variable.
So yeah, every patient is a little different.
Mm-hmm.
Okay, thank you. And we're going to have our next one. It's a little bit longer. I have primary cutaneous B-cell follicular center lymphoma in one skin location. I have heard this is very rare and noticed there are different approaches to treatments, such as 1 to 2 radiation sessions versus 12 to 15. Can you speak to the differing approaches and point me to any research? The questions keep scrolling and I'm losing the one that I'm on. Approaches, and point me to any research on treatment outcomes and rationale for radiation frequency for people with early stage B-cell follicular center lymphoma.
Well, research is going to be tough. It's a very uncommon disorder that has a superb outlook. So, there's not a whole lot of research about what to do, because whatever we do, the outlook is good. And there's so many different choices. You could do nothing. You could have it injected with steroids. You could have it radiated in the different ways that you mentioned. There's really so many different ways you could approach. Dr. Chung, how do you usually approach a patient like that?
I think that's a really good question. So typically my approach is when they present with a solitary lesion, I tend to proceed with radiation with curative intent. So it tends to be like, a slightly higher dose, usually in about 10 fractions. But then if they kind of start developing multiple lesions, then I think the treatment becomes more palliative, because you can't really radiate all of them. So it becomes harder. And as you said, the prognosis is so good. This is a very indolent cancer. So I tend to inject them with steroids, which patients really like because it's so easy. And it responds really well. If they don't want to do the injections, then I can also do like the boom boom radiation, where over 2 days, very short low dose, and that also works very well.
Okay, thank you. So we've seen a lot of questions today on light therapy, and we're starting to have a few trickle in. One we have is, does the body build an intolerance to light therapy, and does it stop becoming effective?
It's a really good question. So as you build up, so light therapy, you start at a lower dose and then you gradually build up. And as you continue to do the light, your skin does become more tan. And that means that the light is probably not penetrating your skin quite as well, because now your skin has more melanocytes that are blocking the UV light. So I think that over time, your skin does not become as light sensitive to the same dose, and you may have to gradually increase the dose over time. And sometimes if if your skin does not seem to respond as well, you can take a break, wait for your skin to become not quite as tan, and then you can restart, and then it can be more responsive at that time.
Okay, thank you. Should people with primary cutaneous B-cell lymphomas consume a certain type of diet and or avoid certain lifestyle choices such as hair coloring, Botox treatments?
That's a really good question. I'm not aware of any evidence associating diet with cutaneous lymphoma or with hair dye or Botox treatments. With hair dye, the concern for hair dye is that sometimes people can get allergic contact dermatitis to hair dye, and that can cause a rash. But that allergic contact dermatitis is not the same thing as cutaneous T-cell lymphoma. So sometimes patients who develop cutaneous lymphoma tend to have sensitive skin, and if you have an allergic dermatitis to the hair dye, then you might want to avoid it. But if you don't have a history of that, then I don't see a reason why you can't get your hair dyed.
There was actually an old study, maybe this is where the question's coming from. There was an old study looking at incidence of lymphomas and what contributes to it. And it turned out that dark hair dye before 1983 was one of the variables, not after 1983. So I don't know if that's where the question's coming from also.
Oh, it's fascinating.
Yeah, it's interesting. And then sometimes with indolent lymphomas, I have my own theory, but I always kind of urge my patients to try and maintain as good immune function as they can. And the kinds of things that we know do that is kind of what your grandma would say, like get your sleep, don't get stressed out, eat good food, get a moderate amount of exercise. And sometimes with all indolent lymphomas, B or T, I think the host has a little tiny bit of at least control over it, because you see it fluctuate over time. Sometimes in mycosis fungoides, as an example, if somebody has a stressor, you see their skin flare very badly, and then you do absolutely nothing different. And the skin will kind of calm down again after the stressor's gone. And I have a feeling the same thing happens for other indolent B-cell lymphomas like follicular lymphoma or cutaneous B-cell lymphoma.
I think that is so true, because I have seen that a lot of my, like for instance, I have a patient with cutaneous marginal zone lymphoma, which is a very indolent lymphoma. And she always gets more lesions when she has a very stressful event at her workplace. So she is working on reducing her stress right now, and that's been working out for her.
I think we all could do with a little less stress in our lives. And it was an interesting story on the hair dye. Thanks for sharing it. All right, so our next question is about how to help yourself. So I can be my own best advocate. What lab work or testing should be done on a regular basis for stage 1B CTCL MF?
Does that mean you're going to turn into Dr. Google? I personally have a huge problem. I really want my patients to be advocates, but I don't really need them to be their own doctor. For stage 1 mycosis fungoides, I don't do any lab test or screening. I don't know what Dr. Chung does, but I hope that you have a feeling of trust in the physician that's taking care of you as well, so that you don't feel the need to second guess everything that they do. It's really difficult sometimes with the advent of so much information on the internet to try and put it into perspective for somebody that actually hasn't had medical training. I find it really difficult, and sometimes it's very upsetting to patients.
I think that's so true, Dr. Pinter-Brown. I also don't think that any routine lab monitoring is needed or helpful. for stage 1 MF patients. I think that sometimes a lot of time when people are diagnosed, we might check like a routine blood chemistry and things like that just for staging purposes, but that's one time at the time of diagnosis. And once you're diagnosed, you have a skin limited disease that is not in your lymph nodes or blood. And there's, and we follow these patients clinically. And if there's no change that requires us to be worried about disease progression, there's no benefit that additional tests can provide.
That's some really good information to share especially when people are newly diagnosed. It's hard to not go down that rabbit hole of the internet because you're looking for answers. Our next question is, are you aware of any connection between sugary foods and itching?
If the sugary food is alcohol, maybe. Alcohol tends to vasodilate, make your blood vessels, bigger. So there's more blood flow through the skin. I think sometimes just like heat or sweating can increase itching. Alcohol does the same thing. But my friend, the chocolate bar, I don't think so.
Yeah, so it's interesting. Not for mycosis fungoides, but for conditions like acne, there are some like low level evidence to show that foods with a high glycemic index, such as like chocolate, high sugar foods, can trigger acne. So it's possible that it has some sort of inflammatory component to these foods, but there's no, real kind of high level evidence to show that sugary foods has any correlation with skin itching.
Well, it's good to know we can still have our chocolate. So we have received a couple of questions on COVID-19, and I kind of want to combine them into one. And if you want to expand on it, because I'm sure we'll end up with some more. So let me do the two questions. As many of us have received basic COVID vaccines and a booster, what do you advocate relative to a second booster? And then the other one regarding COVID is that does having 1A CTCL impact the immune system's ability to respond to the COVID-19 virus? This patient has seen studies are showing the T cells may have a positive response to the virus. So maybe we can just address COVID-19 and vaccines in general.
Well, when you say T cells have a positive response, your immune system is composed of both B and T cells. So when you get a vaccination or an infection for that matter, both groups of cells have become educated, to that organism. Having said that, for boosters, I would recommend the regular CDC recommendation for a patient with stage 1A or more advanced mycosis fungoides. That is, if you're in the age group where you should get a booster, then you should get a booster. And I guess the corollary question is the booster going to be effective? There's not a lot of information, but I would think that patients with stage 1A mycosis fungoides would function pretty normal immunologically, whereas perhaps people with more advanced disease that have gotten therapy that impacts your immune system might have less of a response.
Yeah, I think that's definitely true. I agree. I think if you have stage 1 and A mycosis fungoides, I don't consider you as necessarily higher risk group for COVID-19 than other people. So I think that you should get the booster. I believe a second booster is recommended by the CDC for people over the age of 50. So if you're in that age group, you should get a second booster. And in stage 1 mycosis fungoides, the abnormal T cells are in your skin, but they're not in your lymph nodes, they're not in your blood. So the T cells in your blood are still normal. So if you get an infection, the T cells in your bloodstream can still mount an immune response.
Okay, that's some great information. We have a couple of questions on Evusheld. So I'm going to go with both of them and then we can do one answer. So the first question is, should it be considered for CTLC? And the second question is, what is it and how does it affect those of us with B cell or T cell lymphoma?
Well, Evusheld is kind of preformed antibodies against COVID so that it gets around some people's inability to respond to vaccines. The people that we know have problems with vaccine responsiveness are particularly people with B cell lymphomas that have gotten rituximab, perhaps people that are getting systemic chemotherapies. And so for those patients, we often offer them Evusheld. It protects people for 6 months. I can't remember if there was anything more on the question, but Dr. Chung, feel free to fill in the gaps.
No, I think that's a good point. I think that if you are like stage 1 MF patient, you don't necessarily need Evusheld unless you have some other comorbidity that puts you in an immunosuppressed condition. I think that people, as Dr. Pinter-Brown said, if you receive some sort of treatment that compromises your immune system, then I think that Evusheld is very reasonable. It also depends on, but because this is a healthcare resource that is hard to get, I think there was also it depends on kind of availability and things like that.
And you did answer both versions of the question, so thank you.
Okay.
All right, so this next question, we actually had someone ask it in one of the other sessions, so it's starting to sound like it's a popular question, is can cutaneous lymphoma, specifically B-cell follicular, spread to your other organs? They go on to ask, since it is a blood cancer, can the bad blood cells eventually cause problem in other organs, particularly if the patient already has a precancerous condition in that organ?
I guess we can't ask what the precancerous condition in the organ is, but if I start to think about precancerous conditions in any organ, it has nothing to do with lymphoma spreading. And actually, we have really good papers to show that about 10 to 15% of people with cutaneous B-cell lymphomas eventually have a systemic disease that's indolent as well.
Yeah, I agree. I think that primary cutaneous follicle center lymphoma is generally a very indolent lymphoma that has excellent prognosis. There is a rare chance of systemic spread, as Dr. Pinter-Brown mentioned, usually to lymph nodes rather than like solid organs. But when they do go to systemic progression, that is also tends to be quite responsive to treatment.
All right, thank you. So this one is a patient was recently diagnosed with MF, and they live in a rural section of Central Oregon. They're 15 miles from a regional hospital. What are the benefits of traveling to a clinic or hospital when there would be more experience for treatment advice?
I think that's a really good question. I think it kind of depends on your stage of disease. If you have really well-controlled early stage mycosis fungoides that is responding to topical steroids and it's, and light therapy, and you're happy with your level of management, then I don't know if you necessarily need to travel like 50 miles to a referral center if you're happy with your level of control. If you are not happy with your level of control, then I think there is benefit to seeking out a referral center to see if there's any other treatments that we can try to provide.
There might be one other reason to go to a center. The other reason would be kind of to ascertain that your diagnosis is correct, that your staging is correct, and get kind of a roadmap, if you will, for your doctor to follow. And then you've established a relationship with this center. So if you have issues that come up, you have somebody that knows you, that can answer. And all right, dermatology is a little hard on Zoom, but it actually is sort of kind of doable. So in the era of COVID, one of the useful things that we've gotten in medicine is the ability sometimes to do consultations distantly. And I find that just so useful because I can talk to anybody anywhere in the world, and they can send me pictures, or they can hold up their arm, or what have you. So you might look into the opportunity to do something by telehealth. Dr. Chung, you probably know exactly what the opportunities are in Oregon.
Yeah, so I do telehealth as well, so I'm happy to do a virtual visit here at OHSU. If you send in photos, I can look at them, and then we can schedule a virtual visit. And I also, as Dr. Pinter-Brown said, I have a lot of patients who live far away that I co-manage with their local dermatologist. So I'll see them one time, and then I say, well, if you're doing well, you don't need to come see me again, but if you're not, then let me know. and then they continue to follow up with their local dermatologist, and then we are in a communication with the local dermatologist.
Thank you both. That is, I think, one of the silver linings of COVID was moving us fast forward into telehealth. All right, our next question, are either of you aware of a connection between prolonged skin infections, such as fungal or cirrhosis? I'm not even sure. We're going to go with such as fungal, and CTCL MF being triggered as a consequence?
Well, there's Dr. Duvek's data that staph superantigens may make the skin look worse. Some people have postulated that chronic eczema may evolve into mycosis fungoides, but that, of course, is never proven. It would be so difficult to prove. Aside from those two thoughts, I don't know of any other connection. Do you, Dr. Chung?
I'm not aware of a connection between a fungal infection leading to cutaneous T-cell lymphoma. I do know that people with cutaneous T-cell lymphoma are at a higher predisposition to skin infections, including bacterial, especially staph, and as well as fungal infections. But I don't think there's data to show that infections induce cutaneous T-cell lymphoma.
All right, thank you. And this kind of ties right into our next question that we get this question, and it's a difficult one to answer, but have scientists determined the cause of CTCL?
Easy answer, no. That one's easy. Although there's probably some illnesses that are associated with its inception, just like with all lymphomas. We know that certain patient populations have a higher risk of lymphoma because they either have an immune deficiency that they were born with or was acquired, or their immune systems aren't normal, like we talked about rheumatoid arthritis. There's some lymphomas that are associated with infections, but mycosis fungoides isn't necessarily one of them. But in the end, we don't really know what the cause is.
Yeah, we don't really know. As Dr. Pinter-Brown mentioned before, there's some theories suggesting that maybe chronic stimulation of the white blood cells in your skin maybe lead to this kind of generation of this lymphoma in your skin homing lymphocytes or white blood cells, but it's a theory and we don't really know what causes this disease.
Okay, thank you. What are the pros and cons of photophoresis?
The pros that it's easy.
Sorry?
The pro is that it's pretty easy as a
Yes.
systemic treatment, and you have to have a place that has the machine. And the con is that it only works in certain groups of patients.
Yeah, I totally agree. Well, I think the pros is that the side effect profile is minimal. So everyone tolerates it very well, and you can do it in almost anyone. The con is that availability. So you have to go to a center that has ECP, and often those centers are limited. So people have to travel very far. And typically treatments are given over 2 consecutive days every 2 to 4 weeks. So it's very hard for people to travel 2 consecutive days to a very far distance. And I think that another con is that there's a very select group of patients that I think it works well for. And I think for me, and Dr. Pinter-Brown can add what she does. From my perspective, it doesn't work as well as a monotherapy. I think it's really kind of more of an adjunctive treatment for a certain group of people. What do you think, Dr. Pinter-Brown?
I use it as monotherapy, but I thought of another con, and that may be kind of related to what you're saying. It takes an extraordinarily long time to work. Yeah. So we kind of start assessing people at like 6 months. Some people may not be happy doing that, and hence there may be something else added to kind of hasten a response. So, I think we have so many different tools to treat people that ECP is probably utilized for a pretty select group at this point, I would think.
Yeah, I agree.
I think it is.
Yeah, you have to live close by. You have to be willing to come in often. and you have to be patient. So I agree.
All right, thank you for sharing both the pros and cons on that one. Question is that do you see a place for vitamin D in helping with T cell? Yay, vitamin D.
My soapbox has arrived. This is something I've been interested in my entire career. So vitamin D has to do with immunity, and we actually see some of that during COVID because people that are vitamin D deficient don't do as well. And it's true for other lymphomas too. Hodgkin's, it's been seen in follicular lymphoma. So it's such a simple fix, right? So I check all my patients' vitamin D, and I really urge them to at least make it normal so that it's not, in the single digits, which is actually pretty frequent, even though I'm in Los Angeles, believe it or not.
Dr. Chung, do you have anything to add, or do we want to move on?
Yeah, and I think that's a really good point. It's such an easy thing to check. And maybe I'll start checking vitamin D in my MF patients as well. There's a lot of data with vitamin D with various dermatologic conditions. So I think that there is a role that vitamin D plays in the immune system for sure. And like it's such an easy fix, and vitamin D supplementation has other benefits as well for like bones, etc. So,
all right, thank you both. Do you consider MF-CD8 positive as being indolent?
So MF is usually CD4 positive, but you can have many variations of this immunophenotype. So you can have CD8 positive MF, you can have CD8, CD4 positive, you can have CD4, CD8 negative. So to our knowledge, this variance in immunophenotype has not been shown to be correlated with your prognosis. So I treat CD8 positive mycosis fungoides patients the same way I treat CD4 positive mycosis fungoides patients.
Totally agree. But there's some CD8 skin lymphomas that are not as indolent as mycosis fungoides. So it'd be really important to make sure it's really CD8 positive mycosis fungoides would be the only thing I would add, I think.
Right, absolutely.
Right, wonderful. I was told that African American skin does not respond well to light treatments. Have either of you found this to be true?
So African American skin has more melanin in their skin, so they need higher doses of light treatment. So I don't think it's necessarily that you don't respond as well. You just need to start higher. And then you need to, I usually with my African American patients, I increase a little bit more each treatment to get to an overall higher dose than my Caucasian patients.
All right. The next is about preparing for other surgeries. If someone needs a surgical procedure for an unrelated medical condition, are there any precautions or concerns a CTCL patient should have?
Not that I can think of. I think that if you have like kind of very advanced disease, then I think that you are at slightly higher risk for like staph infections and things like that. So I would just be on the mindful of looking out for skin infection. But if other than that, I can't think of any. Dr. Pinter-Brown?
I would agree. Patients with more advanced disease get wound infections.
Yeah.
So I was going to say if the surgery is going through an area where the skin isn't normal, it might be an issue. Other than that, I think the only other considerations would be maybe specific treatments, particularly if they produce low blood counts, that be checked before a surgery. On the whole, though, I'd say I wouldn't worry about it too much. But there may be some specific instances where, you'd want to look out for one thing or another.
All right, thank you. The next question, I'm making an assumption it's someone who is newer diagnosed. I'm going to rearrange the question a little bit. They're specifically asking if there are any treatments that target the white blood cells, because their question is, are all treatments skin related?
No, well, you have to understand what these white blood cells do. So they're mobile. So they have like a circuit when they're normal and when they're abnormal. So their circuit is go through the nodes, go through the blood, lodge in the skin for a while, come back out, go through the lymphatics, around, around, around. So when you do skin-directed therapies, you are directing the therapy to the majority of the malignant cells because they love to be in skin. They're hanging out there. If somebody has a large proportion of cells elsewhere, like in their blood, we do have treatments that will specifically target cells in blood really well. So all of these treatments for mycosis fungoides, they're all directed towards the malignant cell where it happens to be in abundance.
Yes, I think that's perfectly put.
All right. So this one has a little bit of a backstory to it, so bear with me. After phototherapy, both narrowband and PUVA, Targretin combined with Valchlor, and most recent, total skin radiation. Nothing is proven very effective in clearing up my skin. I've noticed since the radiation, the dryness, scaling, and skin peeling has worsened. This is especially concerning as it's on my face, neck, scalp, as well as the not so visible areas. Is this a common side effect of the radiation, and will it clear if radiation related as opposed to being part of the disease itself?
Yeah, I think that's a really complicated question. So when you have mycosis fungoides, you can definitely get skin peeling and you can get like scaling as well. I do see that patients, after they get total skin, they do experience kind of worsening of their skin before it gets better. Typically, the first 2 months after radiation is a time when you might experience more skin peeling and more dryness. This does get better on its own. So I think that sometimes a little bit of time is needed to see what's the radiation-related change and what is kind of progression of your mycosis fungoides. What do you think, Dr. Pinter-Brown?
Well, I'm bothered a little bit by the fact that all these treatments have failed, and I want to say that total skin is really great at clearing up somebody's skin, but it doesn't last forever. And so often, people will have kind of the backup plan, and they'll institute the backup plan right as the radiation completes so that the skin stays good. And the backup plan might be something systemic, you know, might be a pill. So I think I would ask a little bit what the next plan is for you, whoever asked the question, you being whoever asked the question.
Yeah.
What's
Yeah,
the
I
backup
agree.
plan?
Yeah. Yeah, typically I do tend to kind of put patients on a maintenance regimen as they're coming off of radiation, because I do think that it helps kind of prolong the duration of the radiation benefit. So whether it be oral methotrexate or oral Targretin, I do think that it is helpful to go back on the regimen. And you know, radiation, as Dr. Pinter-Brown said, is not a cure. So it's just something to like help kind of calm down the activity. So it's really kind of an adjuvant treatment.
All right, thank you. Any connection of Hashimoto and MF?
No, there's a connection between Hashimoto's and marginal zone lymphoma of the thyroid, but that's not MF. So I can't think of any other connection.
Yeah, me neither. I'm not aware of any.
All right, thank you. We learned in a previous session that people with cutaneous lymphoma struggle with the quality of life with this disease for various reasons. What words of wisdom would you give us to improve our quality of life?
Moisturize your skin would be my first statement.
Yeah, I definitely think that skincare is really important, and it's something that's hard. And I think that often patients kind of have difficulty with it because it's something that requires a lot of discipline. Like taking a pill is very fast, whereas putting a cream on your body takes a lot of work. But I think that people who actually do it every day do experience a ton of benefit from it. I think people often underestimate the amount of benefit that people can have from a steroid cream because it's a cream, so it doesn't feel like it would do a lot, but it actually does really help kind of maintain your skin and improve your skin if you're able to do it.
Okay, great. So we have a follow-up question on mRNA. Was wondering if either of you had read the November 2021 case report from Belgium, where the mRNA vaccines have created rapid progression of T-cell lymphomas per the NIH report.
I saw a report that talked about specifically patients with MF. It wasn't rapid progression, it was a relapse. I don't know if that's what you're referring to, and I think it was, I want to say it's 3 patients, something like that. So it's really interesting, and I bet all of us that treat people with lymphoma are watching to see if there's any connection between the vaccine and lymphomas. But you can imagine the difficulty that anyone would have tying the two together, because mycosis fungoides relapses. So it has to relapse at some point, whether it relapsed, a week after you got the vaccine or the week before, or, a month later. It's very hard to know if there was a cause and effect there.
Yeah, I totally agree. So I think that this was with angioimmunoblastic T-cell lymphoma, not mycosis fungoides from my knowledge. But nevertheless, I want to echo what Dr. Pinter-Brown said. So it was a case report. So case reports are very hard because they often have very kind of alarming or kind of very shocking information that gets a lot of press attention. But you also have to interpret it with a lot of caution because it's anecdotal, and then you also have to there's no proof for causation. For example, there's like a lot of case reports about certain medications triggering aggressive flare of mycosis fungoides. But I think that you have to remember that, as Dr. Pinter-Brown said, this is a disease that waxes and wanes and will flare over time. So I think that right now we don't have a lot of evidence to show that the two things are necessarily related.
It's really great information to share. So we have a couple of questions on creams and moisturizing. I'm going to combine the two. And the first is it safe to use over-the-counter itch creams? And then what types of creams would you recommend for moisturizing? And that's it.
Yeah, so I don't know which over-the-counter. So there's a lot of over-the-counter anti-itch creams, I think. So it's a kind of hard for me to make a general statement. But in general, it's I think that I tend to recommend using kind of bland moisturizers. And I think the moisturizers are kind of the most beneficial for your skin itch, rather than like things that contain a lot of different ingredients that potentially you can develop a skin allergy to. So the ones that I like, I don't know if I'm allowed to say brands, but like, Cetaphil, CeraVe, Vanicream, those brands tend to make pretty bland, fragrance-free moisturizers that I like.
All right. Next question is, are there any positive effects or values to having lymph drainage therapies?
Not that we know.
Yeah.
Unless somebody has lymphedema. If somebody has lymphedema, massage is helpful because it moves the lymph and the limb isn't as swollen. But other than that, no, not that I've ever seen.
Yeah, I'm not quite sure what this lymph drainage therapy is. I'd have to kind of learn more about what this means, but I've never referred any of my patients for this. So I don't think that it's something that we often do.
Right, thank you. In general, how long can one use clobetasol during MF flare-ups?
This is a really good question. And I love clobetasol. And I actually kind of there was this study that was done a while back about giving potent topical steroids like clobetasol to mycosis fungoides patients. And they had them use it twice a day for 3 months straight. And that actually caused like clearance of a significant percentage of patients. And of course, the disease came back. And there were some patients who had some like skin thinning and things like that, which are the side effects that you can typically see with topical steroids. But it is reversible. So when you stop it, the skin thinning does get better. So I think that, so I am not that aggressive with topical steroids. I don't tell people to use it straight for 3 months, but I do typically say that if you get a new lesion that's really thick and inflamed, you can use it twice a day for about a month and then kind of taper off when it's better. And because a lot of mycosis fungoides lesions don't go away completely, I tell people, well, if it's, seems like your normal kind of stable disease, then you can maybe use it about 3 times a week. And then if it flares again, you can go back to the kind of more aggressive regimen. What do you think, Dr. Pinter-Brown?
I think the key word you used was thick. So
yeah, thick. Yes.
The thicker the skin or the lesion is, the less you have to worry about skin thinning or absorption of the steroid if you're putting it on very big areas.
Mm-hmm.
We use a lot of clobetasol too. I wouldn't use it for 3 months though either.
No, but this was like this was pretty amazing. They got like they reported like a 90% clearance of the lesions after 3 months.
Wow. Wow, that is a lot.
It's one of those things like on TV where they say don't attempt this at home.
Yeah, exactly. This was in a controlled
don't do
environment.
This, without talking to your doctor.
Exactly. Yes.
Only under medical supervision.
Mm-hmm.
Okay, so we have a question on targretin, and what they're asking is it all right to go off and on? Their cholesterol skyrocketed when they were on it, so they're happy to stop taking it. But with the reoccurring patches, they may want to start taking it again. So, what has your experience been with that?
Well,
what do you think, Dr. Pinter-Brown? Yeah.
Anytime you expose a cancer cell on and off to an agent, you encourage resistance. You wouldn't want to do it on purpose. Sometimes people have to hold for a week or two because their triglycerides went up and we have to get it under better control, but then we reinstitute it. So I would say that in general, you wouldn't want to plan to go on and off of it, but sometimes people have to go off for short periods of time. And if somebody's off it for a really long time and you reinstitute it, then you would stand less chance that the cell would still remember, that it had this once before and it might work again.
Yeah, I think that's very true. I don't think it's helpful, like if you kind of like take it on, take it off, like kind of intermittently. I don't think it necessarily works that way. But if you have to take a break because of your triglycerides, and I think that's unavoidable. But I agree that I don't think going on and off frequently is good for resistance.
You bring up a good point, though. Bexarotene takes like 4 months to work, oral bexarotene.
Yeah.
So that's what you're referring to. Excuse me, why it wouldn't be so smart to go on and off. It's not like topical steroids where you expect a pretty rapid response. Bexarotene needs to kind of get going there for 4 months. And if you're going on and off of it very rapidly, you're not really seeing the benefit of the drug.
Exactly. And I feel like that's the case with a lot of oral medications for mycosis fungoides, like methotrexate too. It takes a long time for methotrexate to work.
Okay, thank you both. Some good information. Another question on some lotions. Would you recommend ones with uric acid?
You mean like urea?
Urea.
Oh, sorry. You're right. It was a typo. I should have caught that. Urea acids.
Yeah, I actually really like urea-containing moisturizer, especially for the hands and feet. So sometimes patients with really bad mycosis fungoides get really thick hands and feet where that causes cracks and is very painful. In that case, what I typically tell patients to do is put urea 40% on their hands and feet at bedtime and cover with gloves and socks. And that helps really well.
All right, thank you. Before we go to the next question, I want to do a check-in on time. We are down to the last 10 minutes. So if anyone has some questions they haven't managed to put into the Q&A yet, please put them in there. So now we have one of our more new popular questions. Are there any CBD products that have been shown to help with CTCL?
That is a popular question. Not that's been studied. I have patients that come in and tell me they think it's helpful. I don't know if it's the emollient in it, the thing that, makes the skin moist, or the CBD, or none of the above? Because I have to say, a lot of my patients that come in and tell me that they think CBD oil is incredible, come in the next visit and they're not using it anymore. So I'm not really sure why I see that a lot.
Yeah, I don't think there's like good evidence. I do have some patients who swear by it. Some patients like it for their itch. It doesn't really make the lesions go away, but it can help symptomatically with their itch, in which case I say, sure, you feel free to keep using it. But yeah, I agree. I don't have anyone who uses it for a very long time.
All right, thank you. So you had mentioned about an injection into a lesion or plaque. What is it that's injected?
So right now there's like different injectable treatments that are kind of in studies, but right now the one that I inject is topical, like triamcinolone, which is a steroid. So sometimes when you have like a really thick plaque or even a tumor nodule, you can inject with steroids, and it can really help it go down.
Okay. So next question, we actually have had a couple on this today, is have you had patients with oral MF? And could you share a little bit about it? They have a mouthful of lesions and they're getting ready to have some biopsies, and they're very anxious about the biopsies.
It actually is possible.
Yeah, I had a patient who had it inside his mouth, and he had to get radiation for it because it's not an area where we can really treat with topical creams. And it responded really well to radiation. So it can be hard to treat, but it's not impossible. And there are certainly treatments that we can do. I will say I do oral biopsies a lot, and just as part of my being a dermatologist. And don't worry, it's not that bad. It's like the same as a biopsy in any site, and the mouth actually heals really quickly because it's mucosal skin. So we do the biopsy, and then it tends to heal actually faster than any other part of the body.
There's actually oral topical steroids too.
Yes, you can use clobetasol gel.
Use it for graft versus host and other things.
Yeah, yes, clobetasol gel is really helpful.
Okay, thank you. So I'm asking this one, and we've had some kind of questions along it, and I'm kind of teeing you guys up for a standard statement on what is the mortality rate after diagnosis?
There's no answer to that. And the reason there's no answer to that is it depends on the stage, and the information we have is incredibly old. So if you do Dr. Google and you go online and you look at mortality curves, what you're going to see is the mortality that existed when I started doing this in 1980. And it in no way relates to the current mortality. I can tell you from personal experience, having done this for a very long period of time. So unfortunately, we don't know the answer very well.
Yeah, I think that's so true. I think that a lot of patients ask me this at their first visit. What is my life expectancy? What is my mortality? And not only does it depend on the stage, even within the same stage, I feel like mycosis, fungoides, and sugary is such a variable disease. Like patients have such individual kind of courses that even in the same stage, patients don't necessarily behave the same way. And as Dr. Pinter-Brown said, a lot of these mortality studies are from a long time ago, before the advent of a lot of the treatments that we use right now, like brentuximab, mogamulizumab, and things like that. So I think that right now, the field is really changing a lot.
Even in the olden days, though, I would say there's one landmark study that looks at patients with stage 1A and 1B disease that shows that if they're treated, because most people don't go to an academic center and say, fold their arms and say, I refuse to be treated, but you can follow me. If they're treated, that they have a normal lifespan. So I can't imagine that it could be worse, in the last 40 years. So at least you know that, and you know that people with 1B disease also fare extremely well.
Yes,
okay,
absolutely.
Thank you. Yep. So this question is, have you seen anything on where anemia could be a potential cause or an enable of CTCL?
Nope.
I'm not aware of any.
Okay, that ended up being one of the easy ones. So this one is a few questions in one. Is the long-term impact of narrowband UVB? What are the risk rewards, especially someone with stage 1A? And is there a risk of melanoma?
I think that's a really good question. So narrowband UVB, we use a lot more than PUVA, because PUVA, we know from data that if you use it for a long time, you definitely have an increased risk of skin cancer, including melanoma. So the same has not been shown for narrowband UVB. So we have some studies. It's something that's very hard to prove, first of all, because it would require very long-term follow-up. But the data that we have does not show a increased risk of skin cancer with narrowband UVB. That being said, I do see when patients have been getting narrowband UVB for a very long time, I do see other signs of skin aging in those patients, like sunspots, wrinkles and things like that. So I do believe that there is some kind of UV-induced skin damage that comes with long-term phototherapy treatment. So I kind of approach it the same way as I approach any other treatment. I think that you should do it if you need to, but if you don't need to, I try to kind of back off a little bit and then try to do only the amount that is necessary.
All right, thank you. We have time for one more question. What are the chances of stage 1A advancing further?
Well, that goes back to that landmark study. It was 2%. And they tend to be older people and people that didn't respond to their first treatment.
Okay, thank you. And I'm going to do a wrap up here. I want to thank everyone for their questions. And I especially want to thank Dr. Pinter-Brown and Dr. Chung for joining us today. You answered plenty of questions, shared a lot of wonderful knowledge. Unfortunately, we weren't able to get to all of them, but we will do everything that we can to share information with the questions we weren't able to address after the conference. Also, we do have a quarterly Answers from the Experts webinar. We do. Our next one is in August. So please feel free to join the webinar and we can try and answer more of your questions. Thank you to everyone for attending. And now what we're going to do is I'm going to turn this over to Susan, and she is going to do her closing remarks. So if you go back to the home screen on the portal, and you can join the closing remarks session. And thank you again for joining us today.